Good morning. Good morning to everyone. This is Dr. Nick Tullo with ECG Academy, and I'm here live on a Saturday morning. And this time I use my checklist to make sure that hopefully nothing will go wrong this time. I've been checking my audio and video synchronization, and I think it's going to go well today. So anyway, I have a really cool case to present to you. For those of you who are just tuning in for the first time, and I see we have most of our usual people. Good morning, Matilda and Chris and Brian, Space Fred, Tracy. You know, it's so wonderful to have people from all over the world, Algeria, Australia, tune in. And, you know, I hope you're telling your friends about these live streams because, you know, people ask me, why do you do this? I mean, as a heart rhythm specialist, as a cardiac electrophysiologist, you know, I encounter some complex cases. And, you know, I created ECG Academy because, you know, I'm surrounded by people who, you know, physicians and nurses and technicians who look at a cardiogram and they're just not confident. They're not really sure of what it is. You know, if you have to show it to your friend and say, what do you think this is? Then, you know, you're sort of lacking some practice, some basic stuff. And I remember when I was a medical student, I actually had the pleasure of working with a cardiologist up in Syracuse named David T. Nash. That's right. Dr. Nash was, you know, the penultimate cardiologist. He's a wonderful guy, clinical guy. And we would sit there in the ECG reading room with a stack of cardiograms like this. And you know, I read the usual textbook, the D book, you know, whose name will remain, you know, who will remain nameless. But yet that's just not enough. I mean, you need to be able to sit down with someone and have them show you the nuances, the subtleties, you know, how to actually approach an unknown tracing, because it really takes a lot of practice and you can't pick that up from a textbook. So I created ECG Academy to help you understand ECGs like I do, you know, teach you how to think like an electrophysiologist. But there's something missing from all ECG courses, and that is, what do you do with the patient? So this is sort of like a glimpse into my world and how I deal with patient problems, and hopefully will give you some insights into how to take care of your patients. So that's why I decided to do these live streams. So this is now my 29th, I think. That's pretty good. Good morning, Ramon and Ashke. Thanks very much. And Jens from Denmark, good morning. So nice to see everybody. Anyway, I have a really interesting case, and it involves a 91-year-old fellow. So let me kind of give you a quick history, and then we'll get to the cardiogram. So this 91-year-old man, actually he's pretty healthy. I mean, you don't get to be 91 unless you're made of good protoplasm. So anyway, he does have a history of tachycardia bradycardia syndrome. And about 6 or 8 years ago, someone put a dual chamber pacemaker in the fellow because he had some sinus bradycardia and he had some paroxysmal atrial fibrillation. And I think he was on a small dose of beta blocker just to kind of keep things under control. But for years he did well, except in the last month or two, he's noticed decreased exercise tolerance. He was getting short of breath when he walks. He was getting, you know, weakness. He just wasn't feeling himself. And he finally, you know, he's a stoic guy. He doesn't like going to doctors. So he finally went to, good morning, Leonardo, and Jamshid here. Thanks for joining me. And so he came to the emergency room with his family. And let me show you his cardiogram. So now bring his ECG up, and it looked like this. So this is kind of like, if I showed this on ECG Academy in one of my chalk talks, I think this would be pretty advanced. But when you look at the whole tracing, you can actually see that, let me get my pen up here and pick a nice color. So you can see the QRS complexes down here in the rhythm strip are actually pretty regular, but the rate there is about 135 or 140 beats per minute. The QRS is wide. And looking at V1, you can see a very classic right bundle branch block pattern with in a wide S wave in V5 and V6. And also when you look at the limb leads, it's negative in 2, 3, and AVF, and it's actually positive in AVR. So he has a marked left axis deviation with R waves in the inferior leads, and so he has a left anterior hemiblock. Now, these live streams assume that you know something about reading ECGs. If this all sounds like unfamiliar to you, then definitely check out my videos on the ECG Academy. But what's causing the heart rate to be so fast? Why is it 140 beats a minute? Well, maybe we can zoom in a little bit and let's see. I'm going to drag this up a little bit and let's look at the inferior leads, 2, 3, and AVF. And what I happen to notice, and it's subtle, so not everybody will see this, but there did seem to be a negative deflection in front of each QRS complex, but there was also a negative deflection following each QRS complex. And so it turns out that this was an atypical atrial flutter with an atrial rate in the range of about 260 or so, or maybe faster, and he was conducting 2 to 1. So, I mean, you can see the flutter waves a little bit in lead 2 here, but it's harder to see the second flutter wave in lead 2. Let's just see if I can drag this up and look at V1, because V1 is a good place to look for flutter waves. And you can see this atrial wave in front of the QRS, but because the QRS is wide, it's hard to see the second wave, except right here, there's a little bump on the ST segment, but that bump sort of like disappears here, and here it's definitely gone, and then it's back again. So you can see it's coming and going, and that means it's not part of the QRS complex. It's actually, it's separate from the QRS complex. It's separate from the ST segment, and that's the second flutter wave. Okay, so what we decided was that this was atrial flutter with 2 to 1 conduction, and what we usually would do with this is try to use medications to kind of slow the ventricular response down. So he was already on metoprolol, and with this flutter, his ventricular response was, his blood pressure was running like 105 or so. And, he had a rapid heart rate. So, of course, everybody uses cardizem to try to slow the rate down. And it just wouldn't slow down. I mean, we gave him cardizem. We gave him intravenous metoprolol. We increased his toprol. Now, why is atrial flutter so refractory to rate slowing? I mean, when someone has atrial fibrillation, usually you give them a little cardizem and they slow right down. But did you ever notice, hey, Strong from Strong Cardiology, I know you, you're online too. Hey, thanks for joining me. In Egypt, that's fantastic, really cool. So does anybody know why it's so hard to control the rate with atrial flutter, especially when you have 2 to 1 conduction? Sometimes it's easy, but sometimes it's really challenging. You throw all this medication at them and they won't slow down. There is something called concealed conduction. And again, this is an advanced topic. And the idea is that the AV node behaves in such a way that the faster you stimulate it, the more concealed conduction you get, the worse it conducts. So faster rates will block more in the AV node, and the slower rates will get down more readily. You see what I'm getting at? When you have atrial fibrillation, where the atrial rate may be 350 or 400, those signals have a harder time getting down the AV node. However, hi Philip, thanks for joining me. However, when you have a regular rhythm, especially atrial flutter, where the atrial rate is 280, it's very easy for every other beat to get down. And sometimes if you have a healthy AV node, and after all, this guy's 91 and he's pretty healthy otherwise, we had a very hard time controlling the rate. And so that was the problem, because the more medication we threw at him, the lower his blood pressure was. And what do you want to know? You want to know, why is his blood pressure low? Maybe his heart function is poor. But we did an echo, and his ejection fraction, in fact, was about 70%. If anything, he was a little hypertrophic. So that explains why his blood pressure was kind of low, because he didn't have enough time to fill up. We know that rapid rates compromise diastolic filling time, and that causes low blood pressure to occur. Osman, good morning. Hey, good to see you, buddy. So here we are in New Jersey. We're going to talk about atrial flutter. So what should we do with this 91-year-old with this rapid rate? And he's refractory to the medications that we're giving him to slow his heart rate down. So what are our options? We have a lot of options to offer this fellow, but, after all, he's 91, and you don't want to do anything like terribly aggressive. Now, let's talk about atrial flutter for a minute, okay? So the most common form of atrial flutter is common atrial flutter. Oh, yeah, that makes sense, right? Some people call it typical atrial flutter because you got this nice, juicy sawtooth pattern. I like to call it the Black and Decker syndrome. I don't know if you guys are familiar with the company, Black and Decker. They make tools and saws and stuff, so it looks like a sawtooth, but it's unmistakable. It's very easy to see in the inferior leads. This is not typical atrial flutter. You get these little tiny flutter waves with long isoelectric intervals in between them. So that's pretty good for atypical atrial flutter. Where does atypical atrial flutter usually arise from? Well, most of the time it's the left atrium. So, aggressive people would suggest, well, why don't we just do a flutter ablation, and then we can get rid of the atrial flutter and be done with it. I was reluctant to recommend that in a 91-year-old, because regardless of how healthy they look, at that age, the dominoes can start to fall and you can encounter all sorts of complications. And I just didn't think it was worth doing a transeptal and going through this whole big extensive ablation procedure to get rid of the atrial flutter. Sajad, good morning. Where are you from? Thanks for signing in. So atrial flutter ablation was out. What about a cardioversion? Would anybody just bring him to the lab, put him to sleep, and cardiovert him out of atrial flutter? Well, we were able to interrogate his pacemaker. And what it showed is that, indeed, he was having paroxysmal atrial fibrillation most of the time. And it would last for a few hours or a couple of days or whatever. But the atrial flutter that had been present, the pacemaker showed, had been going on for like a month. So now we know that atrial flutter is due to electrical short circuit usually. It's usually due to reentry. So if we were to cardiovert him, what do you think the chances are that the flutter would just come back? I thought of that. And I was concerned that if we just did a cardioversion for a quick fix, that was only going to be temporary and that he was going to wind up back in the hospital. So, what are our other options? There are medications that we could potentially use. Let's say digoxin. Would anybody use digoxin? Show of hands. I don't see any hands out there, but that's good because digoxin in a 91-year-old, especially if you have sort of marginal renal function, is just asking for trouble, number one, because digoxin toxicity is a serious problem. And in fact, there's a lot of data to suggest that the mortality is higher when you use digoxin in patients with atrial arrhythmias. Does that sound familiar? Anyway, the other problem with digoxin is it does not work directly on the AV node. I don't know about you guys, but digoxin does have effects on the atrial myocardium to hyperpolarize and shorten refractory periods and so forth. So it has some effects on the heart. But most of the time, digoxin works by increasing vagal tone. And by doing so, it kind of indirectly slows AV node conduction down. The problem is that once your sympathetics go up, once a person climbs a flight of stairs, pretty much the clinical effects of digoxin are negated. So they start conducting very rapidly anyway. So that's no good. Digoxin's not good. So what about amiodarone? Would anybody use amiodarone? You can put comments. It's okay. I mean, I don't want to waste your time, and because I know there's about a 5-second delay from the time I actually say something until the time that you actually see it. but it's still kind of interactive. So if anybody wants to throw a question or a suggestion or comment, but if anybody would use amiodarone, that it sometimes will work. Sometimes it will work. In fact, it's an effective drug because it does block the AV node, because it has effects on calcium channels. It does have some beta blocking effects. And for controlling atrial fibrillation, see, Nathan thought of amiodarone. For atrial fibrillation, it's pretty effective in combination with other things to suppress the AV conduction and slow the heart rate down. But piling more and more medications on an old fellow was a little bit of a problem. So what other options do we have? And anyone who wants to come up with another option is welcome to. So I thought, and he's a nice guy, and I didn't want to do anything too crazy, but he liked the idea of taking more and more medications, and certainly his atrial flutter remained rapidly conducting for days. Since he already has a pacemaker, and it was working fine. And so what does that open? It opens a door. It's a golden opportunity, especially in someone. Ramon says ablation. Ablation of what? We talked about ablating the atrial flutter, but I didn't want to do that. But what about ablating his AV node? Okay, a lot of people. I remember when I first went into electrophysiology in 1987. The idea of ablating the AV node was pretty common. It was hard to do back then. We actually used DC current. We'd hook the catheter up to a defibrillator and deliver 200 joules. It was gruesome. But after radiofrequency came out in the late 1980s, it became very easy to ablate people's AV node. Of course, there's a downside to it. It's like trading one problem for another, because now you have someone who was formerly an atrial flutter with 2-to-1 conduction, and they had a rapid rate. Now suddenly you've gotten rid of that issue, and you've given them complete heart block. So they become dependent on the pacemaker. But for the most part, in selected patients, AV node ablation is a very effective way of treating refractory atrial arrhythmias where the patients cannot take adequate AV nodal blocking drugs. And as long as you're not dealing with someone with left ventricular dysfunction, because you don't want to be pacing the right ventricle all the time if you can help it. That's why some people will, if they elect to do an AV node ablation on a particular patient that's not a good candidate for any other kind of ablation, sometimes they'll actually put a biventricular pacemaker to support left ventricular synchrony, because we know 100% RV pacing all the time can lead to a pacemaker-induced cardiomyopathy. So anyway, let's take a look at the tracings again, and we did decide to do an AV node ablation. Here is his original ECG. And so we brought him to the EP lab, and I have some, this is like great, this is like show and tell, because I actually took the trouble to copy some of these videos. So this is what you see in this tracing, and I can draw on it, is that he has a permanent pacemaker. So these are the, wait, let me get my opacity up and pick a nice color. So you have two pacemaker wires. I'll draw in white. Two pacemaker wires coming from above. And this one that's curled up is in the high right atrium, and this one leads to the RV. Actually, it was on the RV septum. So it's a good place to put a right ventricular pacemaker. So if I play this video, what you're actually seeing is me advancing an ablation catheter through a very long sheath up from the groin. So we use these long sheaths to stabilize the ablation catheter. There's another lead in there. This is actually a quadrupolar catheter, just an EP catheter that I'm using to try to find the bundle of His. So once that catheter is up there, we look around and look around to try to find the His bundle. So on the top of this tracing, let me just put a layer that I can draw on. On the top of this tracing, you can see that it's still in 2-to-1 atrial flutter. This is the surface ECG, so it's still going fast. Now this is the high right atrium here. And as you can see, his atrial rate is twice as fast as his ventricular rate, which is what you'd expect in someone with atrial flutter, right? Is 2-to-1 conduction. So the atrial rate up here is somewhere like around 260 or 280 beats per minute. Now this is the His bundle electrogram, and what you can see here is that as you move the catheter around, the signal changes. So here you have, I can see both atrial signals, that's these rapid ones, and then in pink I'll mark the ventricular signal. So these are the ventricles. So where are we here? We're near the annulus. We have the catheter near the tricuspid annulus, so we're recording both A and V. Now I advance the catheter a little bit, and all I see now is V. Okay, that's a little too far in. So I pull the catheter back a little bit, and now what I see are little A's and big V's, and look at that. Right there is a tiny His bundle spike. Right there, that little spike there, that's the His bundle spike. So that's a good target for ablation. So let me show you what that looks like on the fluoro. So in the fluoro image, let's just play this. So now this is an REO projection. Does anybody know what REO projection is? If you work in a cath lab, if you do radiology, if you do cardiology, you know what an REO projection is. So we're basically looking at the heart down the barrel. So the X-rays behind the patient, and the image intensifier is over their left chest wall, kind of at a 45-degree angle, sort of. So you're looking at the heart down the barrel. So you've got the left ventricle is going to look like this. The right ventricle is going to be on this side, more anteriorly, right? So let's go back and look at the image here. Oops, what did I do? All right, let me just get that centered. Okay. So in this view, the spine is over the heart. So the left ventricle is kind of, let me see, am I drawing here? The left ventricle, I guess I have to, do I have to stop it to draw? The left ventricle is over here someplace. Let me increase my opacity again. So the left ventricle chamber is over here. Here's the atrial septum, and the right atrium, you can see the right atrial edge is right there. So actually no, it's a little bit further. That's just one edge of it. So here's the right atrial catheter and the right atrial appendage. Here's the right ventricular catheter, which is on the septum. It's actually pacing the septum, which is a really good place for that catheter to be. This is LAO, not REO, Chris. So left anterior oblique. And so here's the ablation catheter, which right here is kind of pointing towards the septum and right in the region of the His bundle. And in fact, if I show you an REO view now, this is the REO. So now in an REO projection, the heart is this way and you're looking from the side. So the image intensifier is over the patient's right side, and you're looking kind of like this way with the heart pointing towards the right side of the image. All right, so now that we're oriented, so in this image, I still have to bring my intensity up. So the right ventricle is going to be here. So here's the right ventricular cavity, okay? Probably the annulus is here someplace. And you can see the RV pacing wire is in the RV, and the atrial pacing wire is up here in the right atrial appendage. Okay, so with that, and you can play that video, which is kind of cool, you can see that my ablation catheter is right on the annulus. And so what I did now is I turned on the juice. You turn on radio frequency energy, and see what happens. And so here's the recording from the lab when we turned on the RF. And so here on the left-hand side, you're basically still in 2-to-1 atrial flutter. And what you see when I turn on the energy is there's a slight acceleration in the rate. You've got a flurry of activity that's a little bit faster. And that's very common when you are ablating the AV node. And that sort of indicates that the AV nodal tissue is actually being damaged. And look what happens, is that suddenly the heart rate slows down dramatically. Now, he's still conducting here. You can actually see the flutter waves now very nicely up here in lead 2. So those flutter waves become much more apparent now that you're not conducting 2-to-1. But the rate slowed down, except it didn't slow down completely. It just slowed down slightly. And this was like a 20-second burn or whatever. So I was like, nah, this isn't good enough, because what'll happen is whatever damage you did can sometimes heal, and then he'll be back conducting 2-to-1. And in fact, after about 2 minutes or so, he started conducting 2-to-1 again. So what we did was move the catheter back slightly. So this is where we are now. Now let me show you the last one. Okay, you can see where it is now with respect to the annulus. And so no, all we did was we pulled it back slightly. You see the difference? Now this catheter is 2 millimeters in diameter. So we pulled it back maybe 5 millimeters. Maybe not even. See, it went from here to here. And now we turn on the energy, and here he's conducting a little bit slower like before. So let's just, so here he was conducting like maybe 3-to-1, and I was afraid that it was going to speed up again, but we turn on the energy, and all of a sudden we start to see paced beats here and then here, and now you see the pacemaker kicks in. So now what's happened is the pacemaker has taken over. And that's a really good situation. That's what you want. You want that pacemaker to take over. You want basically AV block to occur. And now the heart rate is 60 instead of 130. And it was a great outcome. It was perfect. Now, some people would say, well, gee, you know, what if the pacemaker fails? What if the lead breaks? Or what if, you know, something goes wrong with the pacemaker circuit? What if he forgets to get the battery replaced? You know, is that going to be a serious problem? So in my experience, if you're careful, and it doesn't always work, but if you're careful and you try to burn sort of far back, don't burn the main His bundle. Don't even like lean on the AV node and fry the whole thing. Be ginger, and if you do it right, this is what you'll be left with. Let me show you. When we turn the pacemaker off, this is what we saw. It's a beautiful thing. What do we see? We see opacity is still low. We see the atrial flutter is still there, but the pacemaker has been turned off, and these are his own native QRS complexes. But where is it coming from? Where is it coming? Hey, David and Holly from the UK. Hello. I'm so glad you could join me here. It's a lovely Saturday morning in New Jersey, and we're talking about AV node ablation. So this is a junctional escape. It's relatively low, and the rate's in the 30s, but it's perfect. Why? Because this allows the patient, that's not an idioventricular escape, because look, it still has that right bundle branch block that we saw before, and it still is negative in 2-3 and AVF, so it has the same QRS morphology as his conducted beats. So this is not an idioventricular escape, which might be perhaps unreliable. This is a junctional escape that's conducting with the same aberrancy as before. And we have a rate in the 30s, and it's fabulous, because that means even if the pacemaker fails, he's not going to like die suddenly from asystole, he'll have an escape rhythm. Now, in my experience, as as the healing process goes by, after a few days, the junctional rhythms will sometimes increase in rate. So you actually have a nice little safety net for the patients, which is really, really, really cool. So it turned out that we were able to stop the beta blockers. We were able to stop all the calcium blockers. We didn't have to put them on digoxin. We didn't have to put him on amiodarone. He was pacing perfectly fine. He was comfortable. He was snug as a bug in a rug. And it was just, I think, a really good outcome for this 91-year-old, because now we can just minimize his meds. He had plenty of battery life on his pacemaker. We can always replace it. We can downgrade him to a single chamber when the time comes. But the one thing is that, the anticoagulation is still an issue. And so you have to decide if in a 91-year-old, they still recommend anticoagulation to prevent strokes. This is a clinical decision. You have to weigh the risks and benefits. But certainly if he didn't have any other reason or wasn't predisposed to bleeding or anything, he certainly would be a candidate perhaps for a low dose of one of the DOACs, the direct oral anticoagulation. So, I think this was a great, a great outcome for this old fellow. But I just wanted to share this with you because AV node ablation is kind of become a palliative type of approach. People don't offer AV node ablation much anymore because most of the time you're ablating the cause of the arrhythmia, whether it's atrial flutter or atrial fibrillation or SVT, whatever. It's much better when you can to target the actual arrhythmia, because this doesn't really cure the flutter, but it does relieve the symptoms. And certainly quality of life in people who undergo AV node ablation is generally much, much better than it was before the procedure. So if you guys have any questions, please, throw them up there. I just wanted to remind you, that if you enjoy this content, please subscribe to my YouTube channel down below. It's ECG Doc. There's a link. You can just click on it, and then you'll be subscribed. And then whenever I do these things, usually on a Saturday morning, it's often Friday night, I'll come up with a case. I'm always scouring the charts. I'm always looking for interesting rhythm strips. I call it my strip search. So, and when I find a really interesting clinical case, I put it together usually Friday night, and then I'll send out emails. So make sure you subscribe, and then I'll make sure that, in fact, if you want to, what I'm going to do is try to provide some additional links I think maybe starting next week, some additional links where we can interact a little bit more, and because I have a lot of cool stuff on ECG Academy that you might be interested in looking at. But make sure that you check out ECG Academy if you are interested in learning more about how to read the cardiograms and how to start thinking like a heart rhythm specialist. You know what it's like if the techs and the nurses don't know what to make of a cardiogram, they show the physician. If the internal medicine doctor doesn't know, he turns to a cardiologist. But when the cardiologist is not really sure what's going on, they call the EP, and here I am. So I'm kind of at the top of the pyramid, but I want you guys to be as comfortable with cardiograms as I am, and that's why I do this for you. So thanks very much for spending the time on a Saturday morning. I really appreciate your coming here, and I hope I should be able to do one next week as well. I was on call last week, that's why I didn't get it done. But next week's another week, and until then, have a terrific week and enjoy, take care, and we'll see you next time. Thanks.